morning, everybody. Thank you for joining our webinar titled Hotspotting, Improving Care and Reducing Costs with Innovative Local Data Systems. My name is Jeff Brown. I'm the Executive Director of the Affiliated Accountable Care Organizations at the New Jersey Healthcare Quality Institute, and we're holding this webinar in partnership with the Camden Coalition of Healthcare Providers. I'm also joined by Linda Schwimmer, who's the Vice President of the New Jersey Healthcare Quality Institute, of which the Affiliated ACOs is a program of, and Amanda Melillo, who's our Policy Associate. Before we get started and we hand it off to the Camden Coalition, I just wanted to say a few words to everybody about what the Affiliated Accountable Care Organization is and does. We are a partnership and learning network for redesigning the healthcare delivery system at the community level. We really try to assist our members with things like implementing innovative payment strategies. We support education on care coordination. We try to build partnerships that strengthen healthcare systems and communities. And through fostering learning and collaboration among stakeholders, we really try to create sustainable change that improves patient care and population health. The Camden Coalition of Healthcare Providers is one of our members, as well as the Trenton Health Team, the Greater Newark Healthcare Coalition, the Central Jersey Healthcare Coalition, and a few folks who are new members of ours are on this call, the Inspira Health Network and the Complete Care also we also have recent members who might be on Continuum Health Alliance. With that, I'm going to hand it over to Linda Schwimmer.
Thank you, Jeff, and welcome everyone to the webinar. I want to thank the Camden Coalition of Healthcare Providers and the Nicholson Foundation for making this opportunity possible. Today's webinar is a kickoff of an exciting opportunity to harness the power of data to use the information to identify opportunities for action in your community and to improve health and healthcare delivery in your community. Today you will receive an overview of what hotspotting is, and then if you want to take the next step and apply to work with the Camden Coalition to have them work with you to not only do hotspotting in your area, but also potentially train your team to continue to do it, that is the opportunity that we'll be discussing today. And if you're not sure whether or not you're ready to take that step, there's many steps along the way to get there, and that's what the Quality Institute's ACO Council is all about. So we will be following up at the end of this call with information on how you can contact us, and we can help you out along the way. This whole webinar and what we're working on is really about change. It's about improving healthcare at the community level, and there is no better person to champion that cause than our first presenter today, Dr. Jeffrey Brenner, who's the founder and executive director of the Camden Coalition of Healthcare Providers. He'll also be presenting with Erin Truschel, who's the associate director of data and research and evaluation, and Mark Homowicki, who's the Camden's director of governmental affairs, and he's their general counsel. So with that, Jeff, it's all yours.
Linda, thank you so much, and welcome everyone to the phone call. Thank you for taking time out of your day. I'd like to thank the Nicholson Foundation for being a generous sponsor of this work, both in Camden and also for the Affiliated Accountable Care Organizations, the AACO organization. Without their support, we would not be able to even be half the distance we are in this work. Today we're going to be giving you an overview of how we're using data inside of the organization and talk about an opportunity that we're going to make available to 5 communities in New Jersey. And our broad goal across the country and in New Jersey is to help communities activate their data and begin to use it to better understand the local conditions in their community, and then to plan out and build projects that can begin addressing some of the issues that you identify within the data. We're also we're going to give you an overview to our philosophy and how we use data, give you a sense of the evolution of our hotspotting work. We'll talk about the legal framework that we've been using. We have Mark Humowicki, who's an attorney who works in the Camden Coalition to make sure that we're able to keep the legal framework structured right to do this work. And then we'll talk about next steps in the AACO hotspotting project. The Camden Coalition of Healthcare Providers has been around for 12 years. We are a membership nonprofit focused on the city of Camden. Our vision is to make the city of Camden the first city in the country to improve quality and reduce cost at a city level. There are 79,000 people living in the city of Camden, and the city is the first, second, or third poorest city in the country, one of the most dangerous cities in the country as well. The bulk of healthcare services in Camden are publicly funded through Medicare or Medicaid, and we have a significant number of uninsured patients who are in the midst of being enrolled through the Affordable Care Act, which will only increase the importance of figuring out, once a patient has a healthcare card, that we make sure that they actually have access and care. We're very focused on the delivery system. So our mission is to improve the health status of Camden residents by increasing the capacity, quality, and access to care in the city. So we are not a public health agency. While we're concerned about clean air, clean water, and traditional public health issues in the city of Camden, that's not our direct focus. We're very focused on how to make the healthcare delivery system work better. We believe that the healthcare system is about 100 years behind the rest of our economy. We have applied many modern business practices to manufacturing, to banking, to retail, but that somehow education and healthcare got left behind. And while we have many amazing drugs and gadgets, we are not a productive part of the economy. You know, in many other parts of the economy, you get more and spend less, whereas in healthcare, you seem to spend more and get less as time goes along. So through the Camden Coalition's work, we're trying to apply lots of modern business principles of data-informed decision-making, of segmentation, of clinical redesign through delegation, protocolization, standardization. And I think you'll get that sense from looking at our work today. So I'm now going to pass over the presentation to Aaron Trushill, who has worked with us for about almost 4 years to talk about what hotspotting is and give you examples of how we're using our data. Thank you.
Good morning, everyone. So the crux of this presentation is about how we're using data to do hotspotting. So just to sort of give everyone a primer on what that means is we're using data in Camden to identify patients who are heavy users of the hospital system, understanding their patterns of use, and being able to use that data to design targeted interventions and follow-up programs so that we can change their existing ineffective utilization patterns. So how we came about that was, apologies. So just to ground that, we wanted to ground this in our data philosophy. So data at its core is about building relationships with partners throughout the community. It's a long-term game, and so it means taking small iterative steps towards longer solutions. And so when we think about working with our data, we always look at the outliers. We think that the outliers tell you much more about the system than the means. And so when we start working with the data set, we start to look at where there are unexpected sort of problems and where there are patients that are heavy users of the system and trying to use that as a window into how the system is breaking down. We also think that we should be, as Jeff mentioned, thinking about this as a business problem and not as much as an epidemiologist. So when we approach data, we're thinking more like an advertiser, trying to segment patients into different types of groups and understand what's driving their ineffective utilization patterns. We also think that there's a tremendous amount of insight and stories to be gained from the data that are great for relationship building. They're great for getting publicity around the work that we're doing, and they're great for really designing well-tailored programs to our community. So that's a core piece that we want to reiterate. And as I mentioned, data is an iterative process, so we start small and we continue building, growing, and adding more data to it. And lastly, I think it's important to reiterate that one of the things that we've really benefited from at the Coalition is having a really close-knit data and clinical model where our data analysts are sitting side by side with our clinicians, our project managers, our administration. So as questions arise, there's people that have access to the data and the technical skills to analyze it and answer those questions. So at its core, I think that that's something that we should all be working to replicate in all of our communities. So just to give you a brief history of our Camden Health database and our use of hotspotting here, about 11 years ago, Dr. Brenner was working with an MPH student trying to understand violence and assaults in the EDs in Camden. And so understanding that claims data, which are administrative data records that get collected every time someone goes to the hospital, and within them there's a trove of demographic data, there's diagnosis codes and payer information. We could use that data and tap into it to tell the story of what's going on. So what started serendipitously as an MPH research project sort of really emerged as sifting through the data. We really got a sense of how expensive and how fragmented the healthcare system is. But we started this whole process with IRB agreements with each of the hospitals that allowed us to get claims from each of the hospitals. We standardized and cleaned them. We subjected them to probabilistic matching so we could create a citywide database because we knew our patients were going to multiple institutions, and if we only looked at one hospital's data, we'd only get a very limited window into the problem. And then lastly, we geocoded them so we understood that each patient's address was in there and that we could begin to tell a story about where they were coming from and use that data to help design more tailored interventions. So just to give you a snapshot of what we found, each year about $108 million, and this is growing slightly, is spent on hospital-based care for Camden City residents, and that translates to almost $1,400 per capita. We found that each year roughly half of the Camden City population goes to the hospital either for an ED or an inpatient visit. And that even a larger percentage of patients, 30% of patients in Camden are going to multiple hospitals and 12% are going to all 3 hospitals in 1 year snapshot. So this is our problem solving has to be all inclusive. We can't be thinking about this as one hospital based. And it's important to get data from a broad array to really tell that community-based picture. On the right, you see sort of some of the macro level insights that we gained on both the ED and the inpatient side. A lot of the reasons why people were going to the hospital were for conditions that were better treated in an ambulatory care setting, and that these are each on a yearly basis bringing lots and lots of money into the hospital that could be potentially redirected elsewhere and providing better care in a more efficient setting. So understanding that, we began to drill even deeper into the data, and we saw at an individual level there was a huge concentration of costs. 1% of patients in Camden reflect a little over a quarter of all the costs. If you move that up to 10% of your most expensive patients, it's almost 3/4 of all healthcare expenditures. So there's a tremendous amount of concentration in healthcare costs in Camden, and we see that as an opportunity to dig deeper into who those patients are, what's driving their ineffective hospital utilization, and how can we work to provide better care at a lower cost. Not only do we see that the concentrations are at the individual level, but by, as I said, geocoding the data, we started to see sort of geographic concentrations emerge. So in Camden, 6% of the city blocks account for 20% of the patients and almost 40% of the total receipts. And even more specifically, several buildings in Camden, we noticed on a yearly basis are costing between $1 million and $3 million in hospital costs. And so using the data to create these maps, to build relationships and have that on paper so that we can then start to think about what are the creative solutions we need to be doing to redesign the healthcare delivery system in Camden. The data has been a tremendously powerful tool. One of the things that we want to sort of always reemphasize is when we started thinking about how do we provide better care to our patients, we looked out around the country, and a lot of the interventions that were being developed were all specific to a condition. So the general sort of paradigm for designing a care management intervention was around heart failure or another sort of chronic condition. And if you break each of the different pools of patients down by, say, chronic condition, you'll see that there are individuals in each bucket that are some individuals are very well controlled and you have some very uncontrolled. And so we started to play around with the data and get a sense that there was more, we think, in common with patients across chronic conditions than there is within chronic conditions. And so we started to segment our patients not based on a disease, but more so on how they access the healthcare system. And so you see at the bottom, all of our care management and care coordination efforts here in the Coalition aren't disease specific. They pool patients based on how often they go to the hospital and using that as a window into all the sort of psychosocial and complexities that we think are really at the crux of why people are going to the hospital again and again. So the first sort of strategy that we take is trying to break people into buckets based on how they go to the hospital. So here's a simple crosstab. On one axis, you have the number of ED visits. On the other, you have inpatient visits. And so as you move to either extreme, you have a smaller group of patients that are going a larger amount of times. On the right, you have in Camden in 1 year, almost a little over 350 patients, less than 1% of the total patients that visited the hospital that year, costing $20 million in receipts. On the left, on the lower side, you see the individuals who are going again and again to the ED, so 5+ times to the ED. And in Camden, that represents 5% of the hospital-going population and around 10% of the cost. And so using that to sort of start to segment and think, I mean, if we drill further and further down, we start to see that the inpatient side is a generally older demographic. They have multiple chronic conditions. They have it's a very different population, and interventions that would help sort of alleviate some of that utilization are very different than if we look at the ED side, where you have a younger demographic, you have a lot more behavioral and addiction sort of issues to work around. So starting to use the data to understand what the buckets of patients are and what types of interventions would be amenable, this is the sort of first step that we take. Going from there, we start to drill a little bit further down. We leave diagnosis codes out of our sort of segmentation until the last possible minute. So understanding that this is the sort of highest bucket of hospital inpatient utilizers in Camden, these are the conditions that they're going for, these are the total receipts that they're costing each year, and where do they live, and how can we start to build relationships for. So each step we take, we drill further and further down, but the first sort of core of that is based around hospital utilization. So having gone through this process with our own data, we've been working with communities across the country to take their claims data and other administrative data and subject it to the same lens. And so we've worked with Newark, Maine, and a number of other places in New Jersey and across the country. But in each case, we found the same sort of concentrations of cost at the individual level, at the geographic level. And so we've really been trying to think about ways to spread this work so that others are capable of doing this within their own communities. And I think that this opportunity to work side by side with the AACO represents sort of the next iteration of using our data and our analytic framework to spread that philosophy. And so if you go to the next slide, this is an example of the report that we did with the Maine Care. We took 3 counties of their Medicaid administrative data and broke it apart by populations, by diagnosis cohorts, and really helping them get a sense of what their community looked like, how much was being spent on different types of care, what the different populations were. And so we've done this on a number of bases, but now we're really trying to think about ways to build an easy on-ramp to this work. So we're hoping that this is a really exciting opportunity to free the data in communities across the state. You know, so much has been lost by having data locked up in hospital IT departments where you have providers. I'm sure there's a number of providers on this call that have interesting, innovative solutions that they want to implement, and they want to use the data to sort of help guide those strategies. But by the time they get permissions to ask the IT departments, and they work their way up their clinical chain of command, and then it comes back down to IT command, the questions change, they're misunderstood, or even worse, there's no sort of permission even given to get that data. So I think that together we can work collectively on trying to free the data in each and every one of the people on this call's communities. I want to emphasize that these are simple, not fancy data solutions, that there are all sorts of predictive models out there, but you know, they're based on insurance linear models, and that we think that there's a tremendous amount of insight just by doing exploratory analysis of our data to understand what's going on in each and every community. Also, going back to what I said earlier, I think that we want to promote having an analyst in every office. So as you start to think about ways to bring your community together and think about ACO strategies, it's important to have competent data analysts that can work side by side with all of your staff to help answer these questions. And lastly, that this is a gradual and iterative process. And so this is the first step in what we think is, you know, a larger and larger project. Just a few other housekeeping points. We're sort of working on a hotspotting toolkit that is going to be, I see working in tandem with this, but basically taking all the tools we've learned here and tools we've developed with our partners that we've already done this with, creating a website to serve as sort of a hotspotting 101, where we can have anyone who's completely new to hotspotting to more of an advanced audience of people who work with claims, helping to do this work. So I think as we do this, we're going to be bouncing ideas back and forth, and it's going to be a real learning process where we learn from you as well as you learning from us. So we're really excited about this. You can begin to see the website, and there's some videos up on the website now, and then as we roll stuff up, more and more information will go live. Another piece that I think is an interesting development, everything that we've done now has been very simple. It's been Microsoft Access, it's been data cleaning and ArcGIS. we're trying to lower the barriers as much as possible for communities to do this. One of the really cool tools out there that we're moving more and more of our hotspotting work to is Tableau, which is a business intelligence program that lets you do very quick, very visually appealing visualizations of your data. And so we're moving more and more of our claims analysis to this. And so in this project, we're going to be working to take your data and we're going to be cleaning it, standardizing it across the institutions in your community. We're going to be building shells and Tableau for you to load that data up and begin to gather insights similar to what we've already shown you with our data and some of the other communities. And then we're going to hand that data in Tableau back to you and provide some training on how to continue to manipulate it, create new views and new sort of dashboards to play around with it. So this is sort of a new sort of development on our side, but it's all around the idea of lowering the barriers, creating a much more easier on-ramp to this kind of work. And so now I'm going to pass it off to Mark, who's going to talk about the legal framework for hotspotting.
This is Dr. Brenner. I just want to make it really clear about what our philosophy is on all this, is that one of our core values as an organization is to be open source, which is to freely share all the learning. So up on our website, you'll find manuals, training materials, data models, contracts, anything and everything that we're figuring out and putting together, you're going to find up on that website. We really think that the model used in healthcare of hiring vendors and hiring consultants has not gotten us where we need to be. And we really need institutions, we believe, to begin learning to build this capacity for themselves within their own institution. So we're trying to lower the point of entry for all of you so that you can put these kind of skills together within your own institution or within your own community.
Good morning, everyone. This is Mark. I am General Counsel here at the Camden Coalition. I'm going to talk very briefly about the legal requirements to get access to the data sets that you will need in order to do the sort of hotspotting analysis that Aaron just discussed, and for us to be able to work with you to do that. In order to do this analysis, you're going to need claims data that contains personal health information, which is called PHI, and is therefore protected by HIPAA. The analysis that we're talking about is quality improvement analysis, which falls under healthcare operations and is permissible use under HIPAA. To comply with HIPAA, we're going to need business associate agreements, which are standard agreements between a covered entity and its vendor or its consultant or its partner. We're going to need those sort of business associate agreements in place between those who have the data and those who receive the data. There are probably a number of different types of organizations on this call. Some of you may be a closed hospital system that are looking at hotspotting your own data. Others may be intermediaries like us, where you're bringing together data from multiple systems in a single place. So depending on which institutional arrangement exists, the legal arrangements will be slightly different, but they're all going to follow a fairly standard sort of format. So the slide here takes the more complicated format where you're taking 3 different hospitals and you're bringing the data to a single entity, which would be your entity, and then ultimately to us. So first you're going to have that standard business associates agreement between you and each of the 3 hospitals in this slide. These are standard agreements that covered entities have with all of their vendors who have a need to handle PHI. Depending on where you are in the process, you may already have one of these with the hospital. The agreement is going to cover things like the scope of the permitted use of the data. It's going to talk about the required technology and policies to protect the security and privacy of the PHI, including how the data is transmitted between the parties. It's going to talk about protocols for notification in the event of a breach. But these agreements are very standard. Hospitals have them with a lot of different organizations. These are not that complicated to sort of work out because they fit a formula that's set fairly clearly by HIPAA. As a business associate, you'll be directly responsible for any breach that occurs with respect to PHI. The scope of the permitted use can be narrow or broad. We at the Camden Coalition typically have a broad scope of use because we're providing an array of process improvement and care coordination services with respect to the data. in addition to data analysis. So at a minimum, your agreement is going to have to allow for the sharing of the data with the analysis of the data that we're talking about. So you'll likely want to have an MOU with the covered entity that describes what data they're giving you and for what purpose. If you're the only entity whose data is being analyzed, you won't need this first set of agreements, and there will just be the second set of agreements between your organization and our organization. So however you get the data, there's going to be the standard BAA and MOU, Memo of Understanding, between you and us that will allow us to perform the data analysis on the data sets that you've brought together. This is something that's very standard that we've done in Trenton, in Newark, as well as Maine and Maryland, as Aaron described. This is sort of the summary of how we'd like to proceed. If this doesn't work, there are other options for arranging for the data. If we need to have direct relationship to the hospital and the data is not going to travel through you but directly to us, that's a possibility, and we can have a BAA with the data source itself. There are some disadvantages to that because it sort of cuts you out of the picture. It limits what you're going to be able to do in the future with the data. It also suggests a much more limited one-time relationship. But if that's the necessary first step in order to get the ball rolling and get the trust in place to be able to then later make the step of having you get access to the data, then that's certainly preferable to not doing this at all. For those of you that are going to be moving forward as part of this project, we're happy to provide template business associate agreements and provide technical assistance on legal issues that come up as they relate to accessing the data. There can be some resistance depending on the culture of the different organizations that you're dealing with. We found it's very important to work collaboratively and to take steps together to address the current concerns that the parties may have. If there's anything that we can do to provide assistance in getting the trust of the organizations or explaining how these legal relationships work and assuring the folks that are responsible for the data that the data is going to be safe and it's going to be handled in a way that is compliant with the law and that it should make them feel confident that this is an appropriate use, we are more than happy to play that role. So with that, I'll turn it back to Jeff here.
The one other thing to talk about is we feel strongly that data should not be used to embarrass people. So built into these MOUs are a standard confidentiality agreement. We never release data, without working through a process with the partners about what's going to be released. So for instance, with the state of Maine, we went through several drafts and came to consensus about it, both an internal document and an external document. So we feel like that's a very important part of this whole process about coming to consensus about what piece of the data becomes publicly shared. I think we're going to go ahead and turn it back to Jeff Brown and Linda at the AACO. So thank you very much, and we'll be answering questions.
This is Jeff Brown again. It was a very informative webinar and definitely an incredible opportunity for all the folks on this call. I did want to say, as Dr. Brenner just mentioned, we are going to have a Q&A, so please hold your questions and we'll talk about the logistics for that very shortly. Here you can see a timeline that participants would need to follow to be a part of this process. The big deadline is February 10th, at which point a letter of intent must be submitted. Then after that, we will select the communities, and those selected communities will be informed of the decision. There will be a conference call to answer questions, a signed MOU, and after that signed MOU, participants will need to provide data, and then the actual hotspotting process will be completed. And the last step will be that there will be a training webinar to train the participating communities in how to do this themselves. I should say, if anybody is looking at this and feeling daunted, the Affiliated Accountable Care Organizations is here to help walk you through the process. As I said at the outset of the call, we really try to support our members and interested communities in this work. It's our goal, and through the support of the Nicholson Foundation, to really spread this to as many communities around the state as we can. And that goes, it goes beyond hotspotting. It's also care coordination. It's really looking at innovative ways to redesign care at the community level. So if we could go to the next slide. So this is just breaking down what a letter of intent should include. Again, it must be submitted by February 10th, 2014. So we have about a month to get it done. And it should include the following: key internal stakeholders that are going to be included in the project. It is recommended that there's a project manager really assigned to move this along. This could key internal stakeholders could also include people like chief medical officers, data analysts, for community organizations, maybe a project manager or an executive director or someone at that level, and we can help you identify the right people. It should include an assessment of the participating community's ability to obtain the data, the necessary data from hospitals and other providers, and again, we can help you assess that ability and help you put that together in the letter. And it can also include key external stakeholders, so other people in the community who would be interested in this project or who would sign on to support it. I do know from looking at the RSVP list to this that there are some communities that have multiple people on this call, and in some cases might not even know they're on the call together. So we'll be, as a follow-up, connecting people and making sure that you're all networked and working together. And Amanda is going to talk about our follow-up materials before we move to Q&A.
Hi, so this is Amanda, and I just wanted to thank everyone for participating. We had over 100 people on this call today, so I think that's really exciting, and it's a really great achievement to get this project moving. So I will be sending out the document that you saw on the slide before, the timeline that just shows the progression of the project, and also this slide here and a detailed account of what exactly is needed for the letter of intent, which again is due February 10th. A recording of the webinar will be made available in the coming days. I can send a link out to everyone with the recording and with the slides. And if you have any questions regarding the webinar itself or applying for the project, or more questions about the affiliated accountable care organizations, you can contact me at my email. And again, thank you everyone for participating. I'm going to pass this over to Dr. Brenner and the Camden Coalition to start the question and answer session.
Great. We're going to be doing questions, and there's a technique for putting your hand up and typing a question in. So let's see. There are already some questions, so let's see. There will be a copy of the PowerPoint distributed. How are you marrying prevention programs to hotspotting initiatives? Our programs are really focused on what I would call tertiary prevention. So primary prevention is keeping healthy people healthy. So a mammogram is an example of primary prevention. Secondary prevention are interventions with stable, chronically ill patients. So a stable, reasonably well-controlled diabetic who got sent to diabetic education would be an example of secondary prevention. Tertiary prevention are people who've had an event, so have had a heart attack, have had a hospitalization, have complex medical issues, and tertiary prevention is an attempt to help them really rehabilitate and stay out of the hospital. Almost all of our interventions locally are focused on tertiary prevention because we think that's where all the costs are, and we think for the short term, at least right now, that's where all the savings are. So if you do primary prevention or secondary prevention, you can drive up costs, and the return on investment could be many, many years away. And that's not to say that those aren't societally important, that we should be doing those things, but the mission, vision, and focus of the Camden Coalition right now is addressing the overwhelming number of Camden residents being repeatedly hospitalized unnecessarily because they're having a hard time managing their illnesses. So that's tertiary prevention. So we're using hotspotting or looking at outliers as a way of understanding why those patients are frequently going back to the hospital and how we can do root cause analysis and systems change to build interventions to improve the outcomes for those patients. So there's a very good book called Lean Startup, which is really what our modality is, which is rather than spending a year planning an intervention, you build a minimally functional prototype and then iterate through cycles of continuous improvement and make the intervention better and better and better, which is what we've been doing for the last 6 years with this intervention. The next question is, could you share data on the impact on health use of this data has had, and is there any ability to predict who will become a high utilizer so we can intervene before they get sick? Great question. So the field of population health is about 30 years behind where it should be. We don't fundamentally understand what the key drivers of this are. We don't have a deep understanding like physics has of quarks and electrons and E equals MC squared and F equals MA for population health and healthcare utilization. The reason is that this field is lacking clear definitions. It has a lot of meaningless words. The term care management can apply to plan-based telephonic case management of a nurse in a cubicle and is equally used for programs like ours that are banging on doors and visiting homeless people in tents and chronically ill patients at home. So that's an example of a field that's very immature when it has indefinite terms that don't really mean anything. Also, the data models are not mature, and there are not really basic constructs about how these things work. So let me give you an example. There is a whole field of predictive modeling which says that you find people who are in the middle of utilization who are getting sicker. And I would argue that those predictive models based on claims adjustment are very inaccurate and not very good at predicting who is headed up in their utilization. And the ROI on those patients is not very good. The other philosophy would be to target the worst of the worst, the people who are currently lying in a hospital bed, and focus on them, and that's where a lot of the ROI is. This is not really the place to go deeply into that, but there is some emerging literature to show that the best ROI is by taking care of the sickest patients, because our predictive models are not very good. Focusing on people currently lying in hospital beds is not predictive modeling. It's actually just looking at data sets and surveilling the data for data signals to immediately respond in real time to those data signals to an event that's just happened, which is different than predictive modeling. So we focus in on patients who've had 2 or more admissions in 6 months and show up right at their bedside. We're in the middle of working with MIT to implement a randomized controlled trial, which will be starting in March. And the reason for that is that you cannot test these interventions in any other way except a randomized controlled trial. Pre and post data is highly confounded by a problem called regression to the mean. So the only good way of testing population health interventions is through a randomized controlled trial. There is no cost for being involved in this intervention. The costs are being covered through a grant from the Nicholson Foundation. We include in our Camden intervention right now all patients who are currently insured either in Medicaid, Medicare, or commercial insurance. Most Camden residents are Medicaid, Medicare. Right now, we currently do not enroll patients who are uninsured because our funding is coming through the Center for Medicaid and Medicare.
But on a data analysis point, one of the things that we'll be able to tell you and work with you on your communities is what is the extent of the uninsured population, how is that changing temporarily? And then there's another question that's a follow-up to that. Will the data be combined across sites? No, everybody's data, unless there is an agreement between the sites and there is a geographic proximity and it makes sense to combine them, we are going to be analyzing each site separately. just because, I mean, here in Camden, there's a poor hospital catchment zone that catches the majority of hospitalization visits. It makes sense for us to bring those 3 or 4 hospitals together, but we're not looking to extend that beyond that point. But I think on a larger question, we're trying to have an all-state, all-country claims database that tracks individuals as they move around, as they go outside that catchment zone. So that's in our long-term plans.
There'll be 5 locations that are selected in this process, and what we're looking for are people who have access to data. So having either be a hospital, a set of hospitals with a key partner in the community, but the big impediment to this is getting through the hospital legal departments and then through the IT department to get the data. Once we get the data, this is a fairly, at this point, straightforward and simple process for us to organize the data, clean the data, if necessary, match the data, and then turn it around and show the data back to you.
And one of the things that's on the calendar is that we are going to have a conference to present everyone's data back to them. And so that, while the data is not going to be pooled, they'll be presented simultaneously, and we'll be able to use that as a community sort of event to bring everyone together.
Can you describe how the service would be helpful in developing an advanced illness management program? So we believe that if you're developing a program, that doing some strategic planning from the get-go and having a pretty deep understanding of the number of outliers, how often they're going, what the baseline costs are, it's really going to help you think through your project. Also, we think it's really important to start making some guesses about the segmentation in your community. As we've gone around the country, each community seems to have a different profile of overutilization, and therefore your team structure may be slightly different. Maybe alcohol is a key driver. Maybe there are more heart failure patients. Maybe there's more homeless in your community. So maybe the age distribution is different. Maybe the geography is different. So we see this data as a way of generating hypotheses and building your project in a more thoughtful and informed way. Also, if you're grant writing, if you're working with your administrators, I think this allows you to come back with a much more coherent set of hypotheses around how you're building your project and the problems you're trying to solve.
Yeah, and once you have that data framework, then you have an easy window to do things like an RCT. You don't have to wait for state approval to evaluate a project. You have a ready sort of window into how people are accessing the hospital. Is that going down? I think that this lowers the barrier. So assembling the data and building out the agreements with the hospitals and the relationships is the first step. But then once you have that infrastructure, tapping into it to not only help inform the planning, but help with the evaluation processes, the long-term process, direction we're hoping to go.
So let's take an example. In Camden, there are 5,000 ER overutilizers in a year, but there are 500 inpatient overutilizers in a year. And we can tell you what the baseline costs of both groups are. So a lot of people say the word ER and hospital use all in one phrase, but those are totally different patients with totally different drivers, and you would build a different team structure and a different approach to each. So I think it's a small example of how the power of segmentation. The reason Barack Obama won the election is they exquisitely segmented voters and had a clearly defined message and workflow and outreach plan for each segment. Procter & Gamble is an unbelievably wealthy and powerful Fortune 500 company because they know exactly what kind of cleaner you prefer to use and how you're going to use it. We need to, in the social service and healthcare sector, get as smart as that about how we build interventions. The only place that healthcare segments is in, how we pump up volume in our service delivery models for our heart failure program or our Gamma Knife. It's time to start using segmentation and more effective ways to target interventions as well. So there's a question in here about what we do for a co-occurring serious mental illness or drug or alcohol addiction. We have some resources in-house, and we work with a lot of partners in the community. If you're interested more about our clinical model, which is not really the focus of this discussion today, we have lots and lots and lots of material up online, webinars recorded, manuals, all sorts of training materials about the clinical intervention. We take a complexity approach to this, as Aaron said earlier, because these patients have so many comorbidities. We think that it makes no sense to build outreach programs that exclusively focus on heart failure or diabetes, that this is a comorbidity problem. The question about focusing on breastfeeding and obesity rates. As a family doctor who did OB in Camden for 10 years, this is a crucial and important issue. It is not a key focus right now of the Camden Coalition. We have a small project focused on group visits with pregnant women that does focus in on this, but we're not doing a community-wide effort. Most of our work is with 50 and 60-year-olds who are lying in hospital beds, who've been repeatedly back there in the last 6 months. It's not to say that this other work is not important and shouldn't be done. That's just what our focus is. Are we planning any interventions or education for the providers? We do a tremendous amount of work. Our founding board members are all primary care providers. What we have found is that experiential learning works best with primary care providers. So by sending in, we do a lot of accompaniment where our staff, health coaches, and nurses go with patients to their appointments. And by coaching and prepping the patient ahead of time and making those visits much more structured and functional, we have found that we're training and retraining and winning over the providers, one provider at a time. Providers don't learn very well in lectures, but you can model behavior in an exam room and we think be a lot more effective. How can we reach out to the stakeholders and the hospitals to get involved? I would talk with your chief medical officer. I think that you need to find people who have an emotional reason to care about the problem. So your head of your emergency room, the head of your inpatient hospitalist group, your chief medical officer, your head of discharge planning, are people whose day-to-day work is being negatively impacted by patients who have high lengths of stay and very difficult discharge planning. Those are the people that have an emotional reason and a professional reason to be really upset about the problem and want to address the problem. And then, they and you need to build relationships to the IT department and to the leadership of the hospital to explain why this project is beneficial to everyone. Hospitals can be very risk-averse. Legal departments are risk-averse. IT departments, appropriately, can be risk-averse. So the first selling point is, why is this in everyone's self-interest, to begin to understand the problem and address the problem. And you need a champion within the institution, likely a clinician, that's going to say, this is a really high priority issue. The data collected is the billing data. So this is every time a patient's admitted or discharged, there are a whole set of data collected and encoded. And even if the patient's uninsured, all this data is generated. So this is very, very easy data to get a hold of, very easy data to export. This is not a data problem. It's a motivation challenge, a leadership challenge, and a process of getting through the legal department, and a trust-building challenge.
The question is, will we present summary data from all programs in some fashion to see if that can help others and key stakeholders? Yes, to answer that question, the idea of the community summit is to bring all the people that we work together to have some sort of presentation, to network and talk about our experiences, and use that as a platform to continue the push for increased hotspotting in other communities. And of course, we'd be bringing together all sorts of stakeholders, from hospitals to payers, to others in the healthcare community. So we think that, and most importantly, if we can get patients involved, I mean, a large sort of framework for us working on this is to get patient representation on our board, helping guide the ACO strategies. And so I think having everyone, all stakeholders involved is, essential to this.
The purpose of this project is not to do a data analysis. The purpose of the project is to excite and galvanize your stakeholders around solving a really complicated and intractably difficult problem. And we have found tremendous interest in the insurance industry. United Healthcare has been a really wonderful partner for us locally. I think there's a lot of interest at Horizon NJ Health and other insurers in partnering with providers to address outliers. I think there's a growing recognition in the insurance industry, the hospital industry, amongst ACOs, a whole variety of stakeholders, that the patients most in need are also the patients where you can get the most both financial and practice benefit from focusing in on. There will definitely be, through the analysis, this question about getting a sense of quantitative impact and financial impact. That's absolutely the benefit of this. So, being able to go back up to your management and say, this is costing us a lot of money. We have a subset of uninsured overutilizers who cost X amount last year for which we're not being paid anything, or a set of insured patients that we're providing care with long lengths of stay for which you're really not making any money, and therefore would be a good subset to focus in on because it's a win-win. We think that, there are pockets of win-win no matter how you're currently paid within these data sets. So, question about the variability in cost with regard to post-acute care. What I would say is that we have 100 years worth of waste and unnecessary care built into our healthcare system to mine away. So post-acute care is wasting a lot of money, acute care is wasting a lot of money, specialty care, radiology, pharmaceutical. I mean, every which way we look, we find waste and lack of productivity in healthcare. So, I think we all have our work cut out for us. So there's a question about whether if you've worked on a community health needs assessment that was funded by Robert Wood with 2 hospitals and a catchment of 2 counties, would this be a good area?
Yeah, I mean, one of the important pieces that we all come together on is defining a concrete geography that we're sort of working to serve, and I think that having something that's narrow in scope and really concentrated really makes sense from a community standpoint, because a lot of these strategies are going to be sort of city or perhaps 1 county level focus. So 2 counties, I mean, we can talk offline about this, but 2 counties might make sense, but we probably strongly encourage you to think more, locally than that.
This work is all about baby steps. So success begets success begets success. So start with something small, do it well, learn a lot, and then come back to your stakeholders and say, wasn't that an amazing process? Let's widen it up and grow the process. So, one of the failings of public health, I believe, is to be 1 inch deep on too much. And our focus is to go 1 mile deep on a problem you can solve. Another question about catchment and expansion. So, once again, the same point, which is, we've done big analysis, we've done small analysis, and, I would really pick a geography you can actually get something done in, because the next step once you build the data set is going to be a pilot project, we hope, to perhaps start working with some patients. You don't want staff running across 2 counties. In the end, you're going to want to try a pilot in 1 neighborhood or 1 small geography. There's a question about records from outpatient settings and matching in and understanding the relationship between outpatient data and inpatient data. This is a wonderful question that we're beginning to get into in Camden. We did not initially have the outpatient data. We do have now some outpatient data sets. You know, I think that's step 2 in this work. So I would start with your inpatient data, but clearly there's a strong relationship. As we think as patients get better and better outpatient care, they shift from the inpatient setting to the outpatient setting. So a lot of the evidence-based interventions that have been tested in randomized controlled trials do see an increase in primary care visits and specialty visits as you create a concomitant decrease in inpatient care. There's absolutely edits and lots of problems in billing data. Every data set you play with has lots of messiness. The data gets you know, corrected and overwritten when a claim is denied or a claim's paid, and that's just the fun of data. It's you know, a very human and messy process. Patients' names get misspelled, their dates of birth are wrong. One of the techniques we use is called probabilistic linkage, which is a fuzzy logic that allows you to match messy data sets. So if Jose Rodriguez gets his date of birth wrong or misentered at another hospital, in a lot of cases, you're still able to match the data across institutions. And I think that's all of the questions. So Jeff, we'll turn it back over to you guys.
Thank you. Thank you, Dr. Brenner. Thank you to the other folks at the Camden Coalitions of Healthcare Providers. I'd also like to, again, thank the Nicholson Foundation for making this work possible, and thank everyone for joining in on this call. Again, we're sending follow-up materials. We're going to send the timeline, the table of important dates that we showed, details on the letter of intent. We're also going to include a study that Rutgers did detailing potential savings in 13 communities around the state, as that would be useful to people on the call in terms of trying to figure out how much potential savings could be generated through some of the initiatives we've been talking about. We're also going to include membership materials on the affiliated accountable care organizations. You know, part of the inclusion in this is inclusion in our learning network. We really want this to be a partnership for more accountable, data-driven, community-based and community-based care, and that's really achieved through collaboration, trust, and education, which is really what we try to foster at the affiliated ACOs. So again, thank you all for joining. We look forward to working with you all, and look for some follow-up materials from Amanda Melillo in the very near future. Thank you. That's the end of the call.